Hello and welcome to the TXRECs educational series. This session is being recorded and will be posted on the TXRECs.org webinars page if you want to review the content or share the information with your friends and colleagues. Patrick Casey will be explaining how PMCH, PQRS, e-prescribing, and meaningful use do or do not interact. All attendees have been muted to block out background noise. If you have any questions for Patrick, please post them in the chat block of the GoToWebinar pane. Your question will be read to him at the end of his presentation. If you're unable to answer your question during the allotted time, you will receive an answer via email. Oops. First, a little background on Patrick. He is the Meaningful Use and Quality Assurance Specialist for North Texas Regional Extension Center. Patrick's career has taken him through a wide range of functions in the private and public sector companies, the common thread of which has been process reengineering through implementation of information technology and data analytics. After almost 20 years of applying IT solutions in and with a wide range of companies across many industries, he began working as a consultant serving primary care practices, implementing customizable documentation solutions. In 2008, Patrick joined a development team on a 2-year project to design and bring to market an EHR system for small to medium-sized primary care practices. In 2011, he joined the TXREC as a Meaningful Use Quality Assurance Specialist. Thank you for joining us, and I will now turn the webinar over to Patrick.
Thank you, Sheila.
You're welcome.
Okay, show my screen, but not that. And I'm 1 minute overdue. Uh-oh. Okay, let's see if we can get our slideshow going.
There you go.
Okay, welcome to the November edition of the TXRECs webinar series. Again, I am Patrick Casey, and a lot of that fancy talk about what I used to do and how I got here basically means that I, over a long career, have helped people change from doing things on paper to doing things on computers. In the defense industry, in the travel industry, hospitality industry, and now I'm in healthcare, which, having been in all those other efforts, I can say this is the most challenging transition from the way we used to do things to the way we hope to do things in the future that I've encountered. So give us some time. It's going to be painful. It's going to continue to be painful, but what we're really talking about here with all these programs is change management. We're changing the way we've done things in the past, which mainly has been on paper, and mainly for individual primary care or individual providers, not just primary care, but individual providers. And now we're wanting to capture and spread that data around more so that we can move to a more collaborative model. And the government, which regulates all the industries I've been in the past, is also regulating healthcare, and because they're also paying into healthcare as a significant payer, they're incentivizing folks and ultimately penalizing folks for doing or not doing things the way they want them done. So that's why we have these programs. And my title says that I'm the Meaningful Use Specialist. I still am trying to find out who volunteered me for this considerable task of describing these 4 things all at once. As a Meaningful Use Specialist, I'm familiar with Meaningful Use, obviously, and I did some research on PCMH for the North Texas Rec in considering doing consulting services around that, but I didn't know much about e-prescribing or PQRS except how to spell them prior to this. And so I spent a good deal of time studying these, and I would say the ultimate benefit is that it put me in your moccasins, as the Iroquois saying is, you don't know somebody until you've walked in their moccasins for a mile. If I were a doctor just coming out of med school, or somebody who just woke up after 20 years and decided that the penalties were getting bad enough I needed to think about these things, I am impressed with the complexity of the business environment that you doctors and practice managers are engaged in and what you're facing here. So I assume that you know something about these, but probably are hoping to learn how they work together through this time, and that's what I'm going to try to do. So we're going to talk about what are they a little bit, each of them, and then help you to decide, can I or should I do them, any of them or all of them, and if so, what's the plan? So we're looking at 4 programs, and the title says PQRS, e-prescribing, PCMH, and meaningful use. That's not the order we'll look at, but what are they? Well, if you look at them at first glance with the glass half empty view, there are a whole lot of programs and practice models with a lot of qualifications, requirements, timelines, policies, systems, and payment arrangements along with penalties. And I don't blame you for feeling that way when you look at it, but let's try to look a little more positively, because this is also the case. If we look at it glass half full, there are potential opportunities for you in your practice to utilize standards and best practices along with financial incentives designed to improve the quality, reduce the cost, and enable more timely and reliable communication between you and other healthcare stakeholders when caring for your patients. Truth is, they're probably a little of both. They're very complicated. They're not all tightly integrated, but they do, if you do them right, they do hold incentives for you and can benefit you not only financially to help you get through the change, but hopefully they will also develop and evolve into significant parts of your practice model and the way you do business, which I believe will only improve with time. That's how it works with this kind of transition, is everybody learns how to do a little bit better. Excuse me. So let's look at them instead of the order of the title by level of increasing complexity. And so if we look from left to right, e-prescribing as a program and as an activity is the least difficult, and I threw ACOs in at the end of this whole thing, even though it's not in the title, kind of to fill out your evolutionary perspective as to where things are headed. All of these programs address actions and processes that go on in providing patient care, so they're trying to modify how you do things. That's correct. They will measure performance against standardized requirements. So it's not an oral exam here. They're actually looking for data that they will measure against standards and empirical numbers and things like that. Therefore, they require submission of supporting data. Some programs require pre-registration, like meaningful use and PCMH, but e-prescribing and PQRS don't. You just submit the data that you have collected. You don't have to pre-register, but you do have to submit the data. Some of the data is collected and reported from computerized systems. A lot of it is, but some things, for example, under meaningful use, you have to demonstrate that you connected to the immunization registry and you submitted a test. That's a little bit more of a manual effort, and some data is submitted manually by the participant. As you get into PCMH programs, not everything can be handled automatically from your EHR, so you can expect to do some number crunching and some collecting of documents and maybe faxing them or submitting or uploading them to their systems, which seems kind of manual when you look at it by comparison. It's not all automated. So generally these programs increase in complexity and effort from left to right. They're programs with incentives and in some cases penalties. All things being equal here, the 3 programs outlined here, e-prescribing, PQRS, and meaningful use, are focused on the provider. They're not practice-based. Whereas PCMH and ACO are more comprehensive and look at the practice as a whole. E-prescribing, PQRS, and meaningful use all have incentives for provider participation, although those incentives can and many times are reassigned by the provider to the practice in order to defray the cost of the EHR, for example. And they can be in the form either of bonuses calculated as a % of Medicare claims or fixed cash payments under Medicare and Medicaid programs. Under the Medicare Meaningful Use Program, for example, a Medicare provider can obtain a percentage up to a limit of their Medicare Part B claims. Under Medicaid, you get, for actually achieving meaningful use, you're going to get an $8,500 check. So it's sometimes a fixed payment, sometimes it's a percentage of your Medicare or Medicare volume. And as I have on the right, there's, for instance, there are different payments, $21,250 for a Medicaid AIU provider. I don't know if you can see that very well, but and then all of these three eventually penalize the provider for non-participation via what are, I love this euphemism, payment adjustments. It's a penalty, guys, to Medicare claims. They're gonna dock you for not doing this if you don't comply with the program and meet the requirements, as in -2 or 0.5%, -0.5% of your physician fee schedule. While PCMHs and ACOs, they're comprehensive care practice payment models aimed at redefining the entire basis of your practice, and they're not just provider focused, they look at your whole practice. And they are as profitable as your negotiated risk or profit sharing arrangements with your payers. I'm not aware of a national PCMH program. CMS is running some, but everything is in pilot stage pretty much now. They're further advanced with private payers in other states. I'm familiar with a lot of things going on with the Blues in North Carolina and Florida, but they are in pilot form, in pilot programs now here in Texas. The benefits and risks are shared as a negotiated percentage of savings or risk, or an incentive for a measurable quality improvement on, say, a targeted condition such as diabetes or asthma. So what's the bottom line on the program incentives and penalties? As an old finance guy, I want to know what my best case is and what my worst case scenario is. It's probably what happens for any given provider or practice is somewhere in the middle, but at least I want to know what my bookends are. And I want to look at it over the long term. So if we look at this, e-prescribing, PQRS, and meaningful use, if you did everything perfectly in 2014, if all the stars aligned and the tides were right and it wasn't the year of the 17-year locust, you could get $63,750 in Medicaid incentives over a 6-year period of first adopting, implementing, or upgrading an EHR, and then 5 more years of meaningful use, plus an additional 0.5% bonus payment on Medicare Part B claims through 2014. So you're starting up with a big incentive. That's the best you could probably do in 2014 and then ongoing for the next few years. Or conversely, if you look at that not participating as not only a penalty but an opportunity cost of not picking up the $64K and the bonus payment, then you give all that away and you're going to look at penalties starting as high as 2% beginning in 2014, and it could grow to a full 9% per year depending on how things go. The meaningful use penalties rise if the population as a whole doesn't reach 75%, I believe it is, meaningful use in the outlying years. They'll raise the penalties beyond 3% a year. And so if you collect all those penalties together, it gets pretty bad when you look at the outlying years. So with PCMHs and ACOs, the payoff is much more dependent, again, on the negotiated deal you make with the payers, but both models are advancing with payers in other parts of the U.S. already. Pilot PCMH programs in Texas are already yielding positive ROIs. Some folks who are members of the REC have told us that they've been doing ACO or PCMH and ACO pilot programs and are looking at significant positive ROIs. So those are down the road, and those are areas where you may have opportunity to, as I said at the beginning, avail yourself of some significant incentives. So let's take a look individually. E-prescribing, you enter prescription orders into a computerized system. Could be an EHR, but it doesn't have to be a full-blown EHR. There are e-prescribing systems that are now just on a mobile device. But it's no longer scribbling on a page. It's entering something via a keyboard or voice recognition, something in a structured format. That means you're filling in fields. and then transmitted securely to a pharmacy system with receipt confirmed electronically by the pharmacy. It's not enough just to send them a fax. I know a fax is over a wire, but it's not the same thing as e-prescribing. That's actually sending the data in a protected, secured format with discrete fields and so forth. So it's different. You've got to enter that data into a computerized system. It requires structured data, and it facilitates checking errors and contraindications on both the front and back end. It allows for checking the prescriptions for the date, the duration, the formulary, the drug allergy that the patient may have, the drug-drug interaction, does some ability to check brand versus generic equivalent checking and things like that. Can't do that as easily or as in an automated fashion and probably as efficiently with a paper methodology. So that's why the powers that be are driving us towards that, is because the computerized system offers a lot more automated things that computers do well. It also allows for rapid confirmation of the receipt, the patient pickup, and insurance reimbursement from the pharmacy, which, depending on how legible your handwriting is, has a significant possibility to reduce errors. Of course, if your typing is terrible, you're still looking at some possible problems there. But again, the computer ought to be able to check and catch that. So, and a benefit that, again, we don't have any studies on it that I can quote, but many anecdotal stories that the result is that there's fewer phone calls back and forth from the pharmacy confirming what you wrote on a little piece of paper, and that is a big benefit not only to you but to your entire staff. The challenges here are that not every pharmacy can do this yet, especially in rural areas where broadband is not exactly perfect or even maybe in place, and so it's not a choice that everybody can make because it may not be an option for you. What does it look like in the long run? It's more and more widely done. It's being adopted more than any of the other programs. It's at 48% was something I just read recently. Non-participation is already penalized under Medicare, with penalties rising up to a -2% of your payments, your claims. It does involve some upfront and ongoing costs, such as hardware connectivity, subscription to the e-prescribing service provider, and there's always, as with all these changes, there will be some, maybe some decrease in your efficiency due to a learning curve. If you've been writing prescriptions on a paper pad for a long time, you're probably pretty good at it, and that's why you do it that way. If you got to start typing into something, be that either a tablet or a regular traditional keyboard, you may not be that fast at it, and so there'll be some cost there. But most practices do realize some benefits, as I mentioned, 30% fewer calls to confirm orders, and it decreases errors relative to all these items we already talked about, even though the alerts that you get, hey, did you see this? Did you check that? Did you consider a generic? Those can be annoying and inconvenient, but and I'll just admit that here, but many folks, again, say that e-prescribing is something once they do it, they would never go back. Should you do it? Probably you should, with few exceptions. We're now into the penalty phase, and often, it's one thing to forego a check to do something that's, 0.5% benefit. It's another thing to have somebody start taking away what you expect to make every year. And this is definitely, e-prescribing is, of all the programs, this one's the one I'm assuring you is here to stay and probably growing, and the penalties are not going to go away. So PQRS. It started out as PQRI. It is the Physician Quality Reporting System. It's in place since 2007, and it was known as PQRI until 2011. It utilizes quality measures. It's been evolving since the late 80s, pretty much because when they started to think about checking quality, there were some early studies that freaked everybody out, freaked out the public, and freaked out the government, kind of, and so they said, we need to find some way of implementing some empirical measures of quality and to incentivize people to adopt them. So until any profession is error-free, you can expect the public and the government to want to take a look at you and find ways to improve quality in the instance of medicine, of course, because we're all talking about human life. It takes on a real high importance and urgency with everybody. So that's where these things came from, was because early checks of hospitals especially resulted in a movement to implement empirical quality measures. And PQRS now is a reporting program that uses a combination of incentive payments and adjustments to promote reporting of quality information by eligible professionals. That comes from CMS.gov, and they're the ones that run this. The incentives are now tailing off. They're now 0.5% of Medicare claims. It started in 2007, and penalties are hitting in 2015. They'll rise thereafter to 2%, negative 2%. You need to report once or twice a year on at least 3 measures selected from a possible 138. They do need to tie to a quarter in 2014. You're looking at reporting for a year. Quality measures are developed specifically by specialist groups. I think this is actually something that is fairly favorable. Instead of having a bureaucrat somewhere decide what they thought, they went to the specialist groups and asked them to develop the quality measures. So quality measures for anesthesiologists are going to be different than they are for primary care or cardiology. And they work with the private sector to come up with these quality measures. Doesn't mean that they're easy to do or necessarily speed your encounters on, but at least they weren't developed by somebody like me, a government-paid bureaucrat who thinks he knows what he's talking about. So, and you do have, in that instance also, if you want to get more involved, some ability to have input with your specialty groups about how those measures are done and what ones might be included and what ones might be taken out. Expect them to be aligned more closely with meaningful use clinical quality measures going forward, and they begin to be more aligned as early as 2014. There's still a small incentive remaining in 2014, as I mentioned, but the rising penalties, again, they hit in 2015 and rise again to negative 2%. Expect private payers to increasingly adopt these measures. They're nationally recognized. They're recognized by the government. They're an easy thing for private payers to adopt without having to maintain the measures themselves or the definitions. So they're going to trickle more and more into private payer pay-for-performance programs. Expect further integration into meaningful use and PCMH measures in the future. So over and above or irrespective of the incentives or penalties, these are going to become a part of practicing medicine and recording the results of your practice of medicine for the foreseeable future. Don't expect them to go away. They're here to stay. Plan on them in your future. Most people, again, start to consider that they need to do it when the penalties begin to hurt, whether the incentives work for you or not. Okay, meaningful use. Today, meaningful use relates, again, most people know it. It's famous because of the EHR incentive programs from CMS, and they hinge on the achievement of the meaningful use standards. But in the long run, expect meaningful use to become a de facto foundation for a lot of other healthcare IT initiatives. It's already profoundly shaped the EHR market, technology development, and provider usage. Expect both public and private initiatives to require and mirror meaningful use. And it's evolving as it goes. As you probably know, it's in stage 1 now. It'll migrate to stage 2 next year, then into the still developing 3, and who knows after that. But it is a long-term program. It's likely in your future, even if you don't participate in any EHR incentive program. So once again, probably not going away. Excuse me. Looking into the near future in 2014, there's a bunch of buzz. Kicks in 2014. Oh my! I say that because I think there's a lot more worry about the effects of stage 2 than is warranted, because not every participant must meet those higher standards yet. In fact, most people who are participating in meaningful use aren't going to be under the stage 2 requirements. It's only those who have been and this will be their third year of participation. So there are some changes that the 2014 Stage 2 rule affects, but it's not going to hit everybody, so not everybody needs to be freaking out. Maybe they'll delay it. Well, don't plan on that. According to Dr. Mostashari, who is the outgoing National Coordinator for Health IT, changing that timeline is a legislative nightmare that takes way too long and requires lots of political cooperation, neither of which do we have a lot of either time nor political cooperation right now, so don't plan on Stage 2 being delayed. There's a lot of professional angst over it and a lot of significant organizations that are asking for it, but changing the timeline is not just a matter of somebody flipping a switch and saying, okay guys, we'll give you another 6 months. It's a law, and that becomes a legislative process, not merely an opinion of somebody on high. So don't plan on it changing. Plan on 2014 being the year that Stage 2 kicks in. The facts are about it in 2014 is that everyone must use an ONC 2014 certified EHR, which is simultaneously capable of reporting both Stage 1 and Stage 2 requirements. Everyone, meaning if you participate in the Meaningful Use Incentive programs, it doesn't matter whether or not you're still under the Stage 1 requirements, which you will be if you're in your first or second year, or if you're in the Stage 2 requirements. You have to use a newly certified, 2014 certified EHR in order to participate. Changes to Stage 1 and new requirements in Stage 2 mean that everyone must increase patient engagement via patient portals. It's not going to be just a matter of being able to exchange data as it was. Now you've got to be able to get the data to the patients, and they have to be able to view, download, or share that data. So that's another 2014 fact. Third is that everyone who participates must report for just a 90-day period in 2014. Originally it looked like, and in the outgoing years, outlying years, if you participate in meaningful use, you're going to have to move from a 90-day to a 1-year schedule. In 2014, because of the new certification requirements that, as I just mentioned, put a real pinch on the vendors to be able to get ready, they didn't think enough vendors or enough providers were going to have enough time to develop, implement, and practice on Stage 2 2014 certified software to be able to make it. So they didn't want the participation dropping off into nothing. So they gave everybody the option of just using a 90-day reporting period in 2014, which means you could be as late as October of next year in getting altogether ready for your reporting period, and you can still make it. So that 90-day reporting period for Medicare participants is tied to calendar quarters because of the integration with PQRS, which is tied to calendar quarters. Medicaid participants who are only eligible for Medicaid EHR incentives may report on any 90-day period during 2014. And according to a recent presentation by ONC, if it's your first year in meaningful use, in any case, either Medicare or Medicaid, you can use any 90 days you want. I didn't read that myself in the rule, but I'm looking for it since the ONC guy said so. So that's worth investigation. The good news, I sort of talked like everybody was afraid of 2014, but the first and second year and new participants either under Medicare or Medicaid need only meet Stage 1, like I said. So that's good news. Medicaid providers may still begin 2014 their participation in the program via a simple adopt, implement, or upgrade of certified EHR technology. Now, it will have to be 2014 certified EHR technology if it's your first year, but you don't have to meet all the requirements for meaningful use. And if you qualify, and if you do adequately attest to adoption, implementation, or upgrading of certified EHR technology, you're still looking at almost $24,000 check per provider. So that's still good news. The Medicaid program runs, the last check there will go out in 2021, so there's plenty of time for Medicaid providers. The Medicare providers, your incentives are beginning to run out and your penalties are starting to stare you in the face. The other good news that is particularly good news with respect to the RECs is that ONC has been authorized for RECs to apply to them for a program extension to continue providing our subsidized, nearly free consulting services to primary care providers through 2014, which means we'll still be here to help. As you may know, if you know anything about the REC program, it looked like in Texas that program was going to run out at the end of this meaningful use reporting period, that is in April of 2014. But we are all applying, and we all hope and expect to be around here to help meaningful use attesters achieve meaningful use through 2014. And we believe that's going to be a big help. It has not been easy for everybody, and we've helped now 3,000 primary care providers get to meaningful use across the state, and we have lots and lots of happy customers who say they couldn't have done it without us. Patient-centered medical home. It is a comprehensive practice model designed to coordinate and integrate care provided by many different agents of care, and with the primary care provider being the center of it, but coordinating that care for patients across the specialists and the therapists and the doctors, not just doctors, but the hospitals, whether that be an inpatient or outpatient environment there. A PCMH means the word home there doesn't mean a facility. It means that's where the patient's care management is housed, and that's where it's centered. So it is a practice management model. There are several models of PCMH. Several may be an understatement. There are 4 big ones, and a lot of variants with the different private payers who have different varying ideas of different measures, but they have the same overarching ideals. I don't have time to go into the details and the differences between, for example, the NCQA model and the Joint Commission. When you're looking at this from a perspective of should I participate in it, becoming a PCMH, it requires significant reworking of your practice management, care coordination, sometimes called team care, office workflow, and closer communication among separate service providers. Obviously, if that's how you already do things, it's not as big a leap for you, but for many providers, that's not how things have been done for a long time, and to move towards a PCMH model is a significant reworking. It practically requires an EHR. I've heard folks say you could do this without one, but I'm loath to figure out how, so it is something that it's going to require the adoption and expertise. You won't be able to do it without being pretty good at your EHR either. So recognition of achievement of the PCMH model comes through submission of supporting documentation to a certifying or recognizing body, such as NCQA. It takes significant time, money, and energy to achieve. This is not one that you just jump into and achieve either at the outset of your practice. According to NCQA, you need to give them some historical data to demonstrate it. And it's not something that you can do in a short period of time. I think the minimum amount of data they're looking for is 90 days, but in most cases it's going to be longer than that. Many payers are piloting this. I'm aware of, again, Blue Cross Blue Shield. I know that CMS has got some pilots, and I believe Aetna is also at it, as well as United Healthcare, I think. So it's something to look into. If you are interested in it, you should talk to your payer partners and see whether or not they have anything in place and have any guidance to help you get there. And then what sorts of financial, again, incentives or renegotiations might be available to you. As a note, ACOs often see PCMH achievement as a qualifying first step for any practice seeking association with them. So it is an evolutionary step in the eyes of many ACOs because it addresses your whole practice. And if you get there, you're a more attractive partner with them in the ACO world. Synergies, how do the programs relate? Well, kind of, sort of, as that graphic demonstrates. They overlap, but not perfectly. In effect, e-prescribing is virtually embedded in PQRS, MU, and meaningful use and PCMH. So it's actually pretty well aligned, but many, but certainly not all of the PQRS measures are embedded in both meaningful use and PCMH. So carefully select your PQRS measures to fulfill the meaningful use measures if you're wanting to do one and then move into the other. Many meaningful use requirements fulfill measures or parts of measures within PCMH, but PCMH has got more requirements. So doing meaningful use is not going to give you a lock on being able to do PCMH quickly or easily, but it certainly is not a waste of time entirely, because many things that are in meaningful use are also required in PCMH. And then, as I just mentioned, PCMH is often viewed as a clinical level stepping stone towards an ACO. So participation in e-prescribing will help you achieve PQRS, meaningful use, and PCMH. Careful selection of PQRS measures will fulfill some, if not all, of the meaningful use CQMs, clinical quality measures. Meaningful use will start you on the road to achieving PCMH, and PCMH will probably help your practice should you want to join an ACO. So how do we take that information and move forward? Well, you need, if you really want to go the whole path of evolution here, you need to plan it. Because the four programs alignment isn't perfect, you need to consider how to plan your practice to develop over the long term. Plan the adoption of technology and practice transformation to maximize efficiency and avoid adventures in rip and replace. What does that mean? If you're going to go towards a PCMH and you're starting out at e-prescribing or PQRS, you're looking at a decision at some point of adopting an EHR. You do not want to adopt an EHR that doesn't have ease of use and achieving meaningful use and a long-term plan to be able to support a PCMH model. Otherwise, you're going to have to rip that thing out and replace it, which is not uncommon, but it's not trivial or pleasant, and it's often quite expensive. So if this is your plan, is to move down this course of evolution, you need to take a look at qualifying your vendors and your consultants who are helping with your change model or your change management based on how well their solutions match the requirements and the programs and the models that you're going to participate in. Which measures, for example, in PQRS and meaningful use under the clinical quality measures, some of those measures are going to fit your practice better than they fit the guy down the street, and you both may be in the same specialty. So you need to qualify your vendors and consultants based on how well their solutions match the requirements of the programs and the models and how well they fit your ability to fulfill those. Plan for time, energy, and money to make these changes. If you're going to go the whole way along this spectrum, it's not free, it's not easy, and it's not trivial. But consider your ROI over the long run. As I mentioned at the outset, I was part of a development and marketing team for an EHR, and it irritated me from day one that the EHR industry, but not only them, practiced or promised that this change model was going to yield ROI in the short run. It probably won't. In most cases it hasn't. There are some cases where it has, where people have been good at it, but your ROI on this is going to be over the long run. If you plan for that, you won't be disappointed that halfway into it you're not making tons of money. But in the long run, it may not only be a matter of profit, it may be a matter of survival. That's my opinion, and you can take it or leave it. But if you look at it in those terms, it gives you the ability to endure the pain of change longer, and that enhances your ability to survive the change and profit from it. I'd like to take the next 3 hours to describe this chart, which is one of our tools that we have, but I don't have 3 hours and you don't want to listen to me that long. It's just an example of the kinds of additional tools that we at the regional extension centers have assembled. That's actually an example of a wall chart that I made for, it prints out 11 by 17, and I think it does a pretty good job of giving you a timeline and the stages and the payments along with the reporting requirements, whether you're Medicare or Medicaid. but I can't, again, I don't have time to do that, and I'm just letting you know that we have lots of these kinds of cool charts at the regional extension centers. I would point you first to our common collaborative website, which is TXRECs.org. It covers all 4 regions of Texas, all the RECs. That's where you are now and listening to this webinar, and there's additional resources and contact numbers and names for getting hold of the persons in the rec that it covers your territory. Healthit.gov, not to be confused with the one that's having all the problems with the health insurance exchanges. I won't mention that. I just want you to remember healthit.gov. Don't get confused with the other one. It is recently and ongoingly updated to include guidance and toolkits like the ones I just showed you, that were previously only available directly to REC consultants. There's been a lot of good work done over the last 3.5 years by recs all over the country and ONC internal and externally hired consultants. A lot of those tools make things like security risk assessments, part of meaningful use, and HIPAA compliance much more understandable and easy to do. Many of the tools can help you gain a grasp of what's involved with moving to EHRs, and recommend that you specifically look at the Provider and Professionals tab for more information. Other resources, of course, the mother of all resources on these programs is cms.gov. They're the official website. They have tip sheets and other tools, and they are the proverbial horse's mouth. So anything you heard here or misunderstood here, I disclaim it all and tell you that CMS is the place that defines how things actually work. They're the gods of the process there. They will tell you how it works, and if they say it works that way, that's how it works. So that is the definitive and authoritative source for all matters concerning these programs, and I advise you take a look at them because there are ins and outs that may or may not fit your particular practice or provider profile. NCQA is a major proponent of a PCMH model, the one that I'm most familiar with. It has training programs and a standard recognition program. It's not free, but it is good stuff, and they do a good job of telling you what those standards are. They're fairly well thought out. They're also evolving. The other one is there are other ones that you will be in touch with if you look at this one, which is the Primary Care Patient-Centered Collaborative, or the Patient-Centered Primary Care Collaborative. I'm not sure which PC comes first there. Sorry, I'm having a brain fart here, or a stroke, whatever it is. A collaborative of stakeholders with interest in PCMH development. Those stakeholders, interestingly, I think this site is interesting because it includes, the collaborative includes employers and payers, so they get to chime in, and it's a fruitful discussion about PCMH from all the perspectives, not just providers. So you get to see kind of what's going on. They have a number of events. MGMA is another good example of an organization that's keeping an eye on this. Particularly, they have a very recent article reviewing a study of PCMH costs and revenues. And if that looks like it's about it, if you have any questions, we can commence on those. I'm hoping that those charts that I briefly showed you are going to be available on the website after this, as well as the slides from this presentation.
Hi, this is Sheila, and yes, they are.
Okay.
The slides that you are presenting from, the documents that you spoke about, along with the recording, will be available on our website.
Okay, the last plug I would like to say, and this will be the sales portion of it, is that the RECs are, as I mentioned, still in business. We still have room for primary care specialists to enroll under the ONC grant to receive additional and continuing help. We expect through 2014 to assist you in your achievement of meaningful use. We have also just very recently signed a contract to include the similar services towards the achievement of meaningful use for Medicaid specialists, specifically cardiologists, endocrinologists, pulmonologists and psychiatrists. So if you are as late in the game as you're about to push the button to a test, but you're not sure and you need a little help, you can give us a call. You can also give us a call if you're looking at achieving meaningful use in 2014. Either case, we have room for you. We are eager and able to help, and we'd love to do so.
Excellent. We have a lot of questions. The first question came, really, the first question came when we was talking about e-prescribing. And
Yeah.
Are there penalties for Medicaid?
Well, there aren't any penalties directly for Medicaid. There are penalties. You will feel the penalties if you take Medicare. If you don't take Medicare, they can, they lop off a percentage of your Medicare payments, and you don't take Medicare, then 5%, 2% of zero is zero. So that's how you have to look at it. If you're a Medicaid only provider, you won't feel the pain.
Cool. Can we do meaningful use for year 1 and year 2 and not the other stages?
Okay, so this is someone who hasn't started yet. Can you drop off? Yeah, you can, but then you open yourself up for, in a given year, for example, in 2013, if you don't achieve meaningful use, CMS is going to look at that and they're going to say, well, they're going to take some time to figure out who did and who didn't during 2014, and then in 2015, they're going to have their, Santa's naughty list, and they're going to know that in 2013 you didn't do it. So in 2015, they will hit you with a penalty. You can participate for a couple of years, but thereafter, if you're not, those 2 years, in other words, will not suffice to keep you from ever having a penalty. They will only suffice for keeping you from having a penalty 2 years hence. I hope that. So the answer is yes, you can do that. There will be longer-term consequences a couple years down the road after you didn't achieve meaningful use in a given year.
So
how did that sound bureaucratic? Sorry.
You have to attest to not get payment adjustments 2 years from now.
That's correct.
You have to attest every year.
Yep.
Okay.
And again, the penalties are on Medicare payments. A Medicaid provider, if that's all you are, there are no penalties
Currently
on Medicaid payments for compliance or non-compliance with meaningful use.
Okay. Oh no, sorry. I answered some of these questions. Also, do you have any programs that offer CEU units? No. Texas Rec does not offer those. What is the fee to have Texas Rec assist primary care office in attesting meaningful use stage 2 in 2014? Each of the recs have a different pay schedule, fee chart. It would be best to call your particular REC and talk to them about it. Would you agree, Patrick?
Yeah, you could also call Congress and say, hey, I think it was really a great idea having recs around to be able to do it for cheap, and why don't you throw some more money at them? Because that's why we have to charge you, is the grant ran out.
That's
right. The grant only covers us for helping folks to achieve meaningful use stage 1, year 1. And we are fully capable of helping people through stage 2, but don't have funding to do that, so we have to charge you at market rates again. So.
Looks like this is the last question. Is there some kind of penalty for not using or acquiring PCMH?
No, the PCMH is not a government program. It doesn't entail any penalties other than the opportunity cost that you might be able to make more money and do move forward with your private payers by negotiating a better deal. But there are no penalties for failing to achieve PCMH. It is really, especially in Texas, it's really in a seed stage and is not a formal expectation at this time.
Okay. All right. While we're waiting to see if there's any additional questions, I'm going to put in a plug for our next webinar. It's going to be in December, the first Wednesday of December, and our presentation will be on meaningful use reporting, benefits beyond the EHR incentives. Bruce Edmonds from West Texas HIT REC will be our speaker. And I don't see any more questions. So thank you, Patrick, for taking time out of your busy day to enlighten us on all these programs.
I hope I did some good.
If you have any additional questions for Patrick, I got to change the slide. Please use the email address that's on the screen now, info@texasrecs.org, and I'll make sure those questions get over to Patrick. And thank you very much for attending today's webinar, and goodbye.
Thanks.